Inviting me on here. This lecture, really, I get this lecture in 2019 to a society called the Far West Athletic Training Association. I did it with a cohort of mine, Mark Reichling. He's the football athletic trainer at UCLA. So pain science, really, this idea of a paradigm shift. What I mean by that is pain science over the years has taken almost like an about face, meaning that it was always thought that pain was a rather mechanistic view of how we experience pain. And now we're learning over the past, I'll say about 15 years through some really smart people in Australia, these physiotherapists in Australia who study pain science to understand what it is. So if we look at pain science and the direct definition in athletic training, or really in any type of society, it's really the physical suffering or discomfort caused by injury or illness. But what we don't know is that how much is truly affecting people when we compare it globally. If we compare it to other types of mortalities and morbidities, such as cancers, heart disease, diabetes, you can see that chronic pain, and let me define chronic pain for you. Chronic pain is pain that's felt about 3 months post. So I'm not talking about acute pain like you sprain your ankle or you get cut by something and you experience pain within the first couple minutes to a week because you have swelling and you have all types of different chemical histamine changes, things like that. It's really related to 3 months post, because what I'm going to explain to you is the data suggests and supports that after 3 months post, many things relatively heal. They'll scar down. Inflammation properties will subside. Tissues will come back to normal regulation, but the pain is still felt with large populations. So I'm going to try to discuss that a little bit. Quick history of pain science. Traditionally, pain, the treatment of pain, how we've been treating pain over the last few centuries has been on this broad spectrum from electromagnetic therapies, ultrasounds, e-stims, massage, corrective therapies, all kinds of injectables, medications, which is probably the #1 way to treat pain. Thank you. Treat pain in the United States is basically what? Eating a pill, right? Your doctor gives you a pill and you eat that pill. And now we have huge problems in the United States, if not globally, related to pain medication overuse. So this idea that something called the gate control theory, was embodied by two people, Wells and Melziak. They created this idea, the gate control theory, which talks about if you experience pain, if I touch fire, I experience pain. It goes right to my central nervous system, and I send that information to my hand, and I pull my hand away. Now we know that that's called a reflex, actually, gate theory. But we know now that as I experience pain, if I touch something, that information has to come back to my central nervous system, up to my brain, right? And then I have to experience that information in order for me to go back down, send a message back down to my hand, and me pull away. That experience over time changes because the brain learns. I'm going to get into that. So how pain is taught today is purely a mechanistic model, meaning that if you get hurt, right? If you hurt your back and you have a disc pathology or a facet pathology or some type of tissue pathology, and you go get an MRI or some type of X-ray, and those come conclusive to suggest that you have something going on, that is a mechanistic thought of pain, meaning that if I have pain and I go to the doctor and the doctor does some imaging and he finds something on an image, such as a slipped disc or a broken bone or something, that is the root cause of my pain. That's a mechanistic view. Now we're learning that over time, 3 months post, that you will continue to have pain and you will build upon that pain. And that pain is no longer mechanistic because tissues heal. What's going on is you're starting to get into what we call the biopsychosocial aspects of pain. Bio is the mechanical. Psychosocial are the experiences related to the pain. That's very important to understand, because biopsychosocial, this Venn diagram of biopsycho and social, can change in size. And as we get older, as we experience the pain through various psychological thought and various experiential thought, various social thoughts, right? Being in different groups, if you're on a team, things like that, where you're having a lot of pressures, pain can get much bigger. And pain doesn't have to be related to this earlier issue related to tissue. So this Venn diagram idea, if you look here to the left, you see bio. Bio means the mechanistic change in tissue that's creating pain. So for instance, you sprain your knee, you twist your knee up where you partially tear your ACL, let's say. Okay, you hurt your knee somehow. You have some swelling. Okay, 0 to 2 weeks, you have some swelling. That's bio. That's the biological change of tissue damage, right? After about 3 months, those things relatively subside, but people tend to stay in pain because now they've learned to be in pain. Their brain has created a new environment based on weight shifting, fear avoidance, people telling them that, hey, be careful with your knee because you sprained it, get on crutches, get in a knee brace, all these things. Now we have the psychosocial. So if you look at the other Venn diagrams, psycho and bio start to become smaller, psychosocial starts to become much bigger. So pain as an experience over time is a kind of a blend of these three. It's not just bio, it's not just a disc, it's not just an ACL, it's not just a sprained ankle, it's not just neck pain, it's not just low back pain, none of that. Over time, you experience all three, and this is where really pain and the shift of pain paradigm is really going. So if we're talking about persistent pain, I'm going to go back to that definition I just spoke about 3 months post. That's what I mean by persistent pain. So you have this idea of nociception, that's a big word for pain. You have incident and trauma, injury, right? Those are the biological factors. Now we got to start thinking about some other factors here, drug dependence, everything that where we use our words. So a lot of times, other things can cause us pain, stressors, just stressors of school and stressors of turning an assignment, stressors of being on a sports team, stressors of being the most ultimate person you can be for that other person, whoever you're trying to do that for. We call that kind of validation. Those things create stressors. Stressors create hormonal responses and endogenous responses in our brain to create more pain. I'll show you some research behind that. And the bottom, you see psychological. A lot of things can help create or bring on the idea of pain, whether they're relationships, work employment relationships, social networks. These things create stressors, and stressors, if you have pain already, can continue to build upon that pain. And lastly, psychological. Depending on what type of person you're, type A or type B type of person, what are your personal beliefs, cultural beliefs, anxiety, fear, depression. So this is just kind of like a cascade of how many things can really cause pain in a person's body. So this is the old method where you hurt your foot, right? You get information from your foot all the way up your periphery to your central spinal column. It sends information to your brain. It sends down information, I hurt my foot. But now what we know is that pain is really just an alarm response. So think about this. Pain is an alarm, meaning that your body is ready to experience pain on a moment's notice because it's a protective response. So we call that nociception. Nociceptors are these nerve endings that are just cover your body like a net or a blanket. And if the nociceptor is pinged or turned on, basically the body will have experienced pain. Now, nociception or pain doesn't tell you the state of the tissues. What I mean by that is that you can minorly sprain your ankle and go into total freak out mode, but on x-ray and MR and initial assessment by an athletic trainer or a medical doctor is quite minimal. Why did you experience so much pain? Because there's a fear factor associated with that. There's also an emotional factor associated with that. There also may be a previous experience of that ankle sprain associated with that. So hopefully you guys are getting the picture that the brain is the governor of all the musculoskeletal system and the nervous system. So if my brain thinks that I'm going to be in pain, guess what? You are going to be in pain. If my brain thinks I just experienced something, now I know I have to breathe and regulate this concept of pain, you may regulate that. It is dependent on your your psycho situation and your social situation and where you are related to how you experience that level of pain. So pain is just an alert system. All it is an alarm. It does not tell you the state of the tissues being hurt. So where we are now is in the rehab setting, in the sports medicine setting, is we're trying to make this shift by explaining pain to our patients. This is a big factor, you guys. We call this a therapeutic alliance. Before, it's like you go in, you get treatment, the physical therapist, the athletic trainer does some treatment on you, and then you're done, right? And hopefully you get better. Now we're trying to integrate the athlete or the patient and have them understand how pain is perceived. If they can understand how pain is perceived, they may be able to mitigate the length of time they're in pain. And this is what the research is showing us. So if we have an input, right, of pain, we know that there's a lot of cognitive control of that pain, how we think and experience, right? There's a lot of emotional change of that pain. So have we experienced this pain before? Where does this pain put me? Does this pain take me out of the game? That's a big emotional response. Does this pain keep me from doing something that I love? That's an emotional response. What is the sensory information coming in? How can I mitigate that? And the output is, can I change? So can I create a better thought process, cognitive? Can I create a more healthier emotional process of pain? Can I help mitigate pain by sensory? What I mean by that is our skin is the largest organ of the body. Touching skin has a change in my output, meaning that when you go get a massage, right, that may feel good. That's a sensory change, not so much a motor change. If I put some type of new vibration gun on my skin because I see a Theragun or Hyperice gun or whatever gun is out there these days, and I massage my body, that changes the sensory perception of pain. So here it is, the input. I can change my thought process, my emotional process, and the sensory input to make a better change of pain control, motor, that's movement, decrease my stress, and decrease my emotional thought process. Okay. When somebody is in pain, there's two types, there's two areas, two basic areas of your brain. There's many areas of your brain, many areas. But the basic areas of your brain that understand threat are called the downstairs brain and the upstairs brain. When you are in threat, and what I mean by that is if August feels pain, right? Now he's scared. He doesn't want to move as much. So the brain just relies on the lower centers of function, meaning that breath control, fight or flight, right? Changing his vagal situation, so changing how he feels throughout the day. That is a lower center. It's not a very high thought process. We need to get people past this downstairs brain by educating them and making them feel better based on basic movements, physical therapy movements, basic treatments, to get them to what we call the neocortex, the higher learning centers of the brain. So if you look at this kind of image I have here, the lower centers of the brain, when somebody's in pain, they stay in fight or flight. Hopefully you guys have heard that term before. If not, that's when your sympathetic nervous system is basically scared. It's fight or flight. You don't have really good breathing. That changes your nervous system. And you stay in this pain response down here, where if we can mitigate that through education, mitigate that through physical therapies, we can get people to the upstairs area of the brain, okay? Get them to basically enjoy things more. When somebody has pain for a long period of time, 3 months post, remember I used that definition, they will develop something called a neurotag related to that pain in their brain. What do I mean by that? The more you experience pain, the more the neural pathway of pain becomes stronger and stronger and stronger. And you develop something called a neurotag. So August feels pain in his low back. MRs are negative, x-rays are negative, ranges of motion are fairly within normal limits. Strength is fairly good. August feels pain every day. It's not mechanical anymore. August potentially feels pain because he developed that new neural pathway, and he has a neurotag related to when he goes to take out the trash and he moves this way, he experiences pain. but everything else checks out. Why does he experience pain? Because he knows that originally throwing out the trash or taking out the trash, doing those movements caused him pain. So his brain remembers that. And what does it do? It pings nociception, and now August feels pain. So August goes to the doctor. All MRs and clinical diagnoses check out. He's given a medication to quell his pain, when pain is really in his brain, so to speak, developed in a new neurological pathway. So these neurotags are basically, they affect our pain response, and it's much more cognitive than it is mechanical. It's not about the state of the tissues anymore. It's more about his thought process regarding that pain. In your brain knows everywhere where your body is. My brain knows where my hand is, my thumb is, my toe is, my mouth, my face. The most information coming from your external environment is your face, mouth, right? Your hands and your feet, right? A baby puts everything in their mouth because that's how they experience the environment. The most information we have coming into our body through our feet, our hands, and our mouth. So that said, when somebody's in pain, excuse me, go back a slide, that area is exquisitely pissed off. And the longer it stays in pain, the more the brain forgets about the area. And now we have this thing called smudging. And our brain doesn't even know where our body is anymore. What I mean by that is, here's my hand. Let's say I injure my thumb, and now it's been 4 months. My brain really doesn't even know where my thumb anymore is. It doesn't really know it is. So my thumb just feels like, it just always feels pain, because pain just will bombard the area because we're not doing any type of techniques over it. Let me give you another example. Phantom limb pain. Somebody loses their foot or their leg or their hand in an auto accident, in some type of United States conflict, whatever the case may be. Your brain still knows where your hand is. So I've treated some of these athletes where they've come back from a duty and they no longer have a hand, right? Their hand was taken off by something. Okay. Their brain still knows where their hand is. If you look back in my cortical homunculus, here's my hand. There's a space for it. It's still in my brain, but my body, physically, my hand isn't there. That patient will explain, Ethan, my hand today feels like a rock hard fist, and it's just aching, but the hand isn't there. So how do you treat that? You got to treat it through the brain. So you basically have to overload the sensory information where the hand used to be. So I basically, where the stump is now, I'd place rock tape on there. I would place, I could do cupping on there. I could do instrument assisted tooling on there. Ways to change the sensory perception to tell my brain I am experiencing a different sensation now other than that clenched fist. It's a very interesting concept. And this example is the biggest example that I can give to you, that people experience pain in their brain, even if they don't have that body part anymore. This was some literature discussing people that have degeneration of body parts. So there's been some research that the older you get, the more on imaging you'll have some type of degeneration. So for instance, I'm 51 years old. You guys are probably in your early 20s. In your early 20s, if we image you, meaning that MRI or X-rays, things like that, you won't have that many type of abnormalities. I'm 51. You can image my whole spine. I have slip disc after slip disc. This shoulder right now, I have a complete rotator cuff tear in the shoulder. Okay, it's completely torn, right? I didn't have surgery on it because I know I can manipulate my strength and my rehab and mitigate my pain after 3 months. I don't need the surgery if I'm not walking on my hands. But the images will show you what? I have a completely torn rotator cuff. My joint, my glenohumeral joint, my shoulder joint is now becoming arthritic, right? So I should be experiencing a lot of pain. But what we see is people that don't have pain will still have strong negative imaging, meaning that I don't have pain in my low back, but I have all kinds of shifting of my lumbar spine, right? That's because I'm older. The moment I experience low back pain, I go to the doctor and I get an image done, and the doctor sees that I have a slip disc of L5S1. he's going to want to do surgery on that. And I've never had any pain there before. So what came first, the imaging or the pain? So I think imaging is really kind of taken out of its context now. Instead of, doctors love to image everything and they rely on those images to do their work, right? When in essence, they may have had that issue for quite some time. And I'm going to show you a study here. Let's see. This abnormal, so this is a prevalence of abnormal hip findings in asymptomatic participants. So what we found here is that young people, 37.8%, 37.8 years, so relatively young, had a lot of degeneration and abnormal hip findings, but they had no pain. Again, a lot of people had abnormal hip findings, but they had no pain. Hope that makes sense to you guys, that imaging has really taken pain to a whole nother level as far as getting surgeries done and trying to treat pain, when pain can be more of a context related to biopsychosocial. This was a study looking at MRIs of professional hockey players. And what they found, professional hockey players had a plethora of tendinopathies of their groin, tendinitises of their groin, hip labral tears, those are injuries to your hip, but had no pain. And at their follow-up, they had no pain at their follow-up looking at the MRI imaging. So again, my point is, you guys, is that imaging will show things that are not increasing the pain. But here's the problem, is that the doctors myopically will look towards that image and say, there's your problem. We better go in there and cut that or some type of repair it. So here's just an idea. Would you perceive more pain if you were stuck in this beautiful flower field and somebody was chasing you, compared to, would you experience more pain if you had to, if somebody was chasing you, you had to run down this dark, scary alley, right? So you can see cognitively, your perception of your external and internal environment will change your pain. Let's talk about this term, placebo. So placebo has been used in the research negatively for years. The term placebo means that is there some type of intervention that they did that changed the outcome? Meaning that if I gave you a Advil to basically reduce your pain, and I gave you a sugar pill to reduce your pain, and the sugar pill worked, that's called a placebo. It didn't have any additive effects in there to actually change pain, but it worked, right? So in the research, that's typically saying, oh, that's, you know, the outcomes of the study were undefined because they responded to a sugar pill. When in essence, in the physical therapy and athletic training world, placebo may be a good thing. It doesn't, well, I don't have to lie to a patient and say this is working because of this, but I can provide all kinds of different treatments, whether they're manual therapies, stimulation, myofascial cups, instrument-assisted tools, tape, all kinds of things. How are those things truly treating the injury? I would say that they treat the injury through neurosensory information. I'm touching skin, but there's also some placebo, meaning that if I tell August that I'm going to treat your lower back with these tools, you will get better within probably 7 to 10 days, as long as you stick to my regimen and my programming. There's probably some placebo in there. And that's okay, because August needs to basically listen to me as far as my recommendations. Hold on one second while I tell my family to be. Sorry about that, I'm zooming from home. So this idea of placebo has been around the research for a long time. And the thing about placebo, let me go back here, is placebo has been just a negative thought process. So now we have these terms called nocebos. Nocebos, meaning that a lot of people within the sports medicine community, such as doctors, chiropractors, physical therapists, athletic trainers, a lot of us use these words called nocebos. Nocebos are words that will increase harm through your words, meaning that, I don't know if any of you have been to the San Bernardino athletic training room, or any athletic training room, or any office for that matter. As you walk in, this is old school, but you walk in and there's posters of people getting hurt. There's a poster of a torn ACL. There's a skeleton standing there with a slip disc that's highlighted red in color, and it looks very, very big and scary. There's all kinds of pictures on the wall of people getting hurt. Those are nocebos, visual nocebos. A verbal nocebo is, oh gosh, August, you really blew out your back. August, your lower back looks like that of an 85-year-old man. Those are negative terms, right? And that's going to scare you. So if you don't have the knowledge on how to help yourself, those nocebos will make you do what? They'll make you stiffen up, try to move less, right? Because you don't want to further hurt yourself. But really what's hurting you is the words. These are harmful and, you know, over time are not good for the outcomes of the patient. So nocebos are big. You have to be careful and choose your words wisely. So with August, I would say, August, we seem to have a situation with your lower back. I feel I can get you better with these days with these types of treatments. Just stick to my regimen, my course, and we'll get better. Those are positive words. People love, I mean, especially in today's current environment, the negative words, the negative terminology will really increase your stress, and it'll increase pain responses if you're in pain already. So those need to be mitigated. Here's an MR. This is a functional MR looking at people that have expectations of pain. So if you look at the bottom slide, people that had lower expectations of pain didn't light up in certain areas of what we call the somatosensory cortex, where the body parts are. People that had high expectations of pain already, they were scared or they were on fight or flight, had lit up in their brain extensively compared to those that did not. So it tells you that there's already neurotags going on, there's already information going on that help them experience pain more than just mechanical. So neuroplasticity, let me define this. This is very important. Your brain is plastic. It can be molded and shaped and changed all the time, okay? Your brain is a series of networks and connections and pathways. If you have a negative pathway and you continue to have a negative pathway, whether it's a thought process, whether it's a movement, whatever the case may be, that pathway will get stronger and stronger and stronger. The nerve will get thicker and thicker, right? It'll become more myelinated, so it's faster and faster. So that becomes your pain, right? That becomes your neural pathway to the negative thought, neural pathway to the poor movement pattern, neural pathway to whatever is causing any information that's negative. We need to learn how to change that. So you need to develop a positive pathway. The more the positive pathway, the negative pathway will soon drop off. It'll basically atrophy, become smaller and smaller and smaller, and you start to use a better pathway. So that's really how rehab works. Creating people to move better, right? Helping them with their positive words, creating better neural pathways to help mitigate the pain. So this can be done through words, this can be done through education, and this can be done through our movement science. So I talked about this guy earlier. This is an image directly out of a book called Explain Pain. So I definitely want to give respect to these authors. This book came out about 15 years ago. Now there's a couple other iterations of the book called Explain Pain. If you guys ever get a chance to read it or are interested, it's actually an easy read for a layman. You don't have to be a scientist or anybody in the medical field to read this book. The authors are Mosley and Butler of Explain Pain. It's a great book, but it talks about this idea of what we call central sensitization, meaning that once you experience pain for a long period of time, that pain is going to be centrally sensitized. That means your brain and your nervous system, your brain and your spinal column. It's no longer in the periphery. So if you have, you know, again, I use that example of losing your hand. If you lost your hand, that pain after a while, if it's not mitigated, is going to be centrally sensitized. It's going to be a thought process. It now has a neurotag. It is now living in your brain. So how do we, I'm just going to give you a couple ideas of how do we treat this. Treatment of people that are in chronic pain or persistent pain, we need to slowly build them up through something called graded exposure. Many times, I'll just say athletic trainers are guilty of this, physical therapists, chiropractors, and everyone who treats people is guilty of too much information too soon, meaning the harder massage is the best way to get the best outcomes. That's not true, okay? The harder you turn up stimulation on something, the more you stretch them harder. More is not better. Less is better to start. We call that graded exposure. If I had a patient on the table, if I'm treating August for his back pain, the example I've been using all morning, I'm going to treat August with no pain response, and I'm going to increase my levels of treatment based on his emotional and physical feedback. If I see August sweating on the table, if I see August pupil dilation change, if I see August biting or clenching his fist based on my treatment, I know that's too much information. I am totally aware of how August is perceiving my information, whether it's hand, stim, tools, whatever the case may be, stretching, okay? So I need to slowly build up August so he has a positive effect of my treatment. As I do that graded exposure, I check out his tissue. How is his tissue tolerating this, right? Is his tissue doing better, right? Is the tissue getting more pissed off and red, right? So I'm going to slowly increase my tissue tolerance, whether it's manual therapies. Then lastly, give a lot more information to the brain through sensory information. Sensory information is me touching the skin. That's just a big word for me, touching the skin with tape, with pods or cups, with tools, with any of those types of things. So this is called baby steps or the biopsychosocial approach to treating pain. So this idea of feeding the sensory system is basically mitigating pain to start. So I don't know if any of you ever been on electrical stimulation or any of you have ever had a piece of kinesiology tape on your skin, but putting things on your skin tells your brain that there's something else going on. When there's something else going on, you can't experience pain at the same time you're feeling something, right? So you're feeling something on your skin, whether that's me touching you or that's a piece of tape, you shouldn't really be feeling pain at the same time. It's a way to gate the pain, I mean, they kind of block the pain. While I block the pain with that passive care, I can start moving those body parts to get you to move to the upper centers of that neocortex, that thought process in my brain. So I don't need to massage muscles as hard as possible or stretch them really, really hard. That'll piss off your nervous system. I'm going to slowly build up sensory neuroinformation on your skin to where you start to feel better so I can move you more. The more I move you, the more larger nerves you're using, and the more you'll feel better related to the pain. So that's called sensory motor retraining. Let's watch this. Okay, let's review this for a second. Somebody took an ink line and drew it around an ant. Now that ant is able-bodied, meaning that he has access to all his legs and he's moving quite well, right? Somebody took a pen and drew a line around him. Now what happened? Now he's threatened by this line. He has what he thinks is a physical barrier that he can't move anymore past that line. Now, I'm not an ant. I don't know the way ants think, but I can tell you this. Threat works the same way. Somebody put a physical barrier around him or her or they, whichever this ant is, right? And now they cannot walk over the line, whether it's the smell of the ink that threatened him, whether it's the texture of the ink that threatened him, whether it's the color, if they see colors, I don't know, but something threatened that ant. This is August with back pain, let's say. August can't feel that he has the ability to move past a barrier because he's threatened. That means he's in the lower center of his brain. He's still on threat. When obviously this ant can walk directly over the line because there's nothing there. So we need to basically let people experience the thought of threat perception and build upon that. So we do that through the baby steps of the biopsychosocial training method. There's other types of treatments that we do for distraction. If you look at this girl right here, she's getting an ice pack on her arm just to give her a better thought process. It's a funny looking bee. Probably shouldn't even be a bee actually because bees sting, but at least it's ice. So she's feeling something different than the injection she's getting. Other distraction methods can be ice, can be heat, can be massage, foam rollers. All those things are distraction methods to not focus on the pain. Basically distract, build you up from there, and slowly get you to more of a movement type of pattern. So this is where we should be, guys. We need to educate our patients. It's so important that patients understand what is pain, and pain is an experience. Pain, again, pain doesn't necessarily have to be the state of the tissues. You can do something very minor. Look at babies. Kids fall down all the time. They fall down and they cry hard. Why do they cry so hard? Because they're in fear that something may have happened. But all they did was basically barely fall. There's nothing going on with the state of the tissues. This transfers to adulthood all the time. Adults may have experienced something with a fall. They fall again, and now they're freaking out, okay? And that'll basically carry over time. So it's always necessary to evaluate an injury and make sure that everything's copacetic. But for the most part, if we let people experience pain and we feed that pain, telling them that they have a disc injury or they have a neck issue, we keep on feeding that, then that pain will continue. It will continue because now we fed that person so much scary information. All the nomenclature is telling us that you should be experiencing pain. Look at these pictures. Look, it's in red. You're having pain. So we need to really we need to change this. And this is where we are today, trying to change the ideas of threat and pain perception. So here's our new challenges. For some people, this is too conceptual, and people are still treating the mechanistic way. They're still just massaging tissue months on end. They're still stretching tissue months on end with no changes in outcomes. It's good that we're doing treatment, but if we're not educating the patient on how pain is interpreted and perceived, then we're really probably not going to get anywhere. So where does the biology end and the psychological process begin? We need to start the process of education right away with the pain patient. I typically have a couple videos I let people watch if I see new patients, or I have a couple leaflets about educating people on pain. Once we get that in their brain right away, we can help mitigate pain. The value of placebo, I talked about that. Placebo is necessary and it may be warranted. Don't negate placebo. You'll read a lot of research articles as you guys continue in your studies through undergraduate and graduate school and so on. You'll see a lot of stuff that says placebo. Placebo is not a bad thing. All right, so here's our takeaway message, guys. Pain is real, okay? If somebody has pain initially, that is real. I'm not saying pain is not real. The extent of pain over time becomes much more related to the emotional, that what we call the affective side, the psychosocial side. The biopain is real in the beginning, but if your parents or your dad or your mom or your grandma or somebody's telling you that they're still having low back pain 5 years later, well, we know now that neurotag is so big in their brain, heck yeah, they're experiencing pain 5 years later. But I'm gonna err on the side that it's probably not just tissue related anymore, it's more psychosocial related. So what do we have to do? We have to change the way they perceive their information, use better choices of words, and slowly build them up through that idea of graded exposure of treatment if you get into that field of treatment. Nomenclature, sorry for the typo there. Nomenclature changes are so big, you guys. You'll see now after this lecture that when you go out there, just look at the narrative of today's current climate. The scare tactics used, that's in medicine too. Scare tactics are used everywhere. We're scared to do anything anymore, okay? Those nomenclatures need to change, and we need to support those ideas of change through the way we use our words. Words do matter. These are my references. I'll leave it at that, and then we'll try to field any questions if you guys have any questions.
I'll kind of start off with the first question.
Sure.
So there's a kind of understanding that for the imaging part, when you're looking at a certain, again, tissue, say like in back pain, and that nowadays primary care physicians or primary care providers, they're focusing on just that one aspect. So I'm guessing my question is, what's the difference? Is it better to do allopathic or osteopathic medicine? You know, to take rather to then look at the singular issue rather than to look at the whole issue as a whole?
So that's a good question. I would say, doctors are myopic, meaning that if you have back pain and now the scheduler schedules you and your primary complaint is back pain, the doctor is going to take images of your low back if that's where the pain is right away. So it's very myopic. The holistic approach will look at everything. It takes a lot more time, and really it takes a lot of patient buy-in. Patient buy-in is so big, you guys, that patients have to buy into the alternate treatments if they want those, or the alternate evaluation methods if they want those. If a doctor or primary care or anybody who's looking myopically at pain, like a chiropractor looking at myopically at a disc, it just doesn't leave room for all the other ways to treat the person. It's myopic. It's going to be that disc. So 9 times out of 10, even at your age, you're going to find something irregular in your lower spine, and the doctor is going to basically focus on that. And that's going to be the issue. Hopefully, those issues are just going to go to conservative care, and you can do a lot of extensive core training, hip training, overall fitness training to get better. But a lot of people go right to the drug and tell people to rest. And that's really not what we're trying to do these days.
For those of you who are here, you guys can feel free and just unmute your mic or type your questions into the chat, and then Dr. Kaiserworth can actually answer the question. But in the meantime, I have another question. How does the perception and the concept of pain might affect socio or psychopaths?
Wow, that's a good question. If somebody's altered, if they're altered mentally, I mean, geez, I can't really experience that. I'm talking about working with able-bodied people. If somebody has some type of altered mental state, hmm, how would you answer that question? What do you think based on my lecture today?
Well, what you were kind of saying is that for the able-bodied people, if you kind of more look at primarily the pain aspect of it. So I think instead of going, because they probably perceive pain differently. So how they perceive maybe psychological pain may be their physical pain to them. So what we can start doing is instead of starting with their pain that they're having currently, what we can do is focus on the psychological and then break it down from there. Because that's how their process is, that's how they're thinking, because they're thinking more psychological rather than physical.
Yeah, I would think that you need a baseline, right? So the person needs to be healthy mentally, right, in order to treat mental health. Because I would say pain science, removing our pain science is the ability to treat cognitively and through education. So if you don't have that baseline of basic good cognitive approaches and mental health, then I don't know, you're going to probably have to treat through some type of mental health situation than you will with education, because my education on pain science probably wouldn't ring well with somebody who's not mentally able to withstand that information. That's my best guess on that. That's a great question. Anybody else? Yeah, go ahead.
Anybody else want to chime in? Because I mean, I have the questions, but you guys can feel free to ask too. So, for the next question, for the nocebo, would it be better to tell the patient their situation or to basically tailor to, like saying you go get better? So, kind of an example. So, say you have a patient who lost their ability to walk, and then you're rehabilitating them to walk again. So, would it be better as a motivator to tell them like this is the situation, like the reality of it, or the actual like you'll get better. There's an end to this. Which one?
Yeah, I think you really have to know your patient well. So that comes with the patient and the provider's relationship. Depending on what kind of person you are. Um, I don't lie, but I definitely don't scare. Right? I used to scare early on in my career. I would scare. Somebody came off the basketball court and they hurt their knee, and I checked their ACL, and their ACL's gone. I'm like, oh man, you tore your ACL bad, man. This is going to be a surgical procedure. Like, that is not the right time to tell that information. A person just went through a huge emotional stressor of hurting himself on game day. Now they have to deal with their parents, being scared to deal with their teammates, worrying about them, and dealing with not being able to play for the coach who basically recruited them, something like that. So that all depends on the person. I would err on the side of not throwing in a bunch of, words and phrases that are going to be negative. I would say, I think we're going to work with you. We have time to work with you now. This is what the research is saying as far as your injury and healing. So showing the current research related to their injury and healing rates and times. I would frame it for them that they have short-term goals. So a short-term goal to be, we should be looking at full range of motion by this week. We should be looking at more strength by this week. We should be looking at more fundamental exercise and movement patterns by this week. So they have short-term goals they can rely on. If we just show them the big picture, sometimes that will scare them. If I say, okay, we're going to have an ACL surgery, if that's the example, you're looking at basically being back to relative fitness by 6 months, not being back to full participation in your sport within 1 year. That's a long time away. And an athlete, if we're just talking about athletes, that's just not tangible. So short-term goals will probably be the answer there.
Great, thank you for your answer. I think that's kind of the question for the pain section, unless anyone has any more questions regarding the presentation. If not, then we'll move on to regarding the kinesiology major here at CSUSD. Anyone? Aaron, Jose, Luis, Maya, anyone?
My typical Zoom class, no one talks. Love it.
Yeah.
Okay. So tell me really quick on your, do you have, tell me your tracks at Cal State University San Bernardino. What are your tracks as far as kines?
Well, again, there's 3 different types. There's kinesiology major as a whole, but then you can kind of go into different sub-concentrations, which are exercise science, pedagogy, and then allied health. They have been implementing kind of what you've kind of been saying lately is the psychological aspect of it. So there's a lot of more requirements for psychology and biopsychology into their programs, at least for allied health. I don't know about exercise science or pedagogy, but they have been implementing these concepts of how can we relate different parts of our body mechanics into our kinesiology related fields.
So you, August, since I'm talking with you mainly right here, what is your track?
So my track is allied health.
Okay, and where do you want to go with that?
My interest is to become a general medical officer.
General what?
General medical officer.
Okay, and what's that? I don't even know what that. General medical officer of military? General officer of what?
Yes, correct.
Military. Okay. So that's a good goal because you have an end point there. Whereas I think a lot of those tracks right there. Here's the way undergraduate works. I think these days is if it's not a determinate end like like a track for athletic trainer where you have to be in an athletic training program, you sit for a board exam and then you become certified in something to get that job. Those tracks you're telling me seem to have open-ended relationships, meaning that they don't end in a terminal certification. They don't end in a terminal job. So if you're going to pedagogy or allied health, that opens you up to go into grad school for physical therapy, into grad school for athletic training. Or you take the CBEST and you become an instructor or professor. Is that where people are typically going with that major, with those majors?
Yeah, a lot of people are choosing allied health and then exercise science because then it kind of branches them off into different aspects of it. Pedagogy. I mean, there's a lot of people actually transferring. A lot of people that I know that they're transferring from exercise science to either pedagogy or allied health because they know like everything closing down. Like the competition is going to be so fierce because of again, there's only so many jobs you can get with exercise science exercise science because it's just primarily, physical trainer or I don't know much about it, but there's not a lot of options, and that's what you're saying is to have students be able to choose the kinesiology aspects that open their horizons to other possibilities rather than just within their job description or job title, right?
Yeah, I mean, pedagogy is much more, teaching how to teach. So you're going to go into more of a secondary school setting, primary school setting potentially, or, advanced school settings such as, colleges and things like that. But, going on to graduate school would probably be, is going to be the choice. It seems most people, unless they have some type of terminal ending to that major, go on to grad school. It seems to be the common thing. I would say that, looking at some of those other majors like exercise science, exercise science, people will sit for continuing education classes with exercise science, meaning they'll sit for the CSCS, the Certified Strength Conditioning Specialist, or they'll sit for the NASM, which is, certified personal trainer, and then they'll build their clientele, whether they start to work for a team, right, as a certified strength conditioning specialist, or they work individual training people as a personal trainer. Now you're looking at business. So you're kind of busy building your clientele and building your business. That depends on the type of person you are. A lot of people are type A and they want to be their own boss, and they like developing programs and they want to work people out, and that's what turns them on. So I think, I think there's still plenty of room for that, because there's so many people with exercise, and especially in today's times where exercise is needed and key for, for fitness and survival and not getting sick. I think, there's still a lot of room for that. So that's more your exercise science. Pedagogy, you're definitely going to move on to some type of teaching option with secondary or primary or even advanced studies, teaching for schools. But again, in California, you have to sit for the CBEST, but I know with a lot of private schools, they don't have CBEST testing, so you may be able to get a job within that realm there too. And then the last one, allied health. Allied health is quite broad. Most colleges have some type of pre-professional major. You guys are calling it allied health, where you're doing undergraduate in something similar to exercise science and all those kind of put together, and then you're going to grad school for physical therapy school, athletic training school, chiropractic, whatever the case may be.
Yeah. So what are some kind of, I kind of question from one of the students is, what are some kind of odd jobs that are not commonly known besides, physical therapists or athletic trainers? So what are some kind of odd jobs within the kinesiology field that you can do for allied health, or you can do for pedagogy, or you can do for exercise science that you know of?
Yeah, I mean, I wouldn't call them odd jobs, but pre-physical therapy or physical therapy assistant. There's small programs called the physical therapy assistant, which are 12-month programs at a community college. There's things called physician extenders, where basically working with the physician hand in hand, doing intake information on patients like that. So working alongside chiropractic assistants, or something called it's called a chiropractic assistant basically, and those are short-term type of education, where you're doing basically 12 months maybe of education on top of what you just did to become an assistant. So those are assistant positions. They're actually pretty good jobs, and with how many people are out there medically treating, they need people. So physical therapy assistant, if you didn't want to sit all the way through a PT program, chiropractic assistant, if you didn't want to sit all the way through a chiropractic program, physician extender, that's more related to an athletic trainer, but I know that people that don't have their athletic training credential do become physical, helping with MDs, so that's possible too. The other stuff is working in schools. Here in California, licensure isn't, we don't have licensure in athletic training. A lot of people help out with the student body or the athletic student population with what knowledge they have, without a degree, believe it or not. So you also can get involved in secondary schools helping out with students.
Maurice asking, he's in allied health and he wants to go into the physician assistant route. So I don't know what's your input on that in terms of being an allied health.
Yeah, PA jobs are, man, that's probably the best job out there. At least it was within the last 5 years. PA, I think that's what he's talking about.
Yeah.
That's a great job. That's no joke. That's basically med school. You're involved with surgeries if that's where you want to be. You're involved seeing patients primarily if the doc or the MD is not in that day. So PA is a great program to go through. I know there's a lot of great programs. I believe Oregon has a great PA program. I'm sure there's many others these days. Education has become quite the variable. So there's all kinds of programs, whether they're um, online, whether they're called limited residency, meaning that you're on campus only so many times a year, or whether they're full residency. But PA has been a big one for years. And I, I would say if I had a second chance of what I'm doing in my life, I probably would have picked PA school, because PA, you're not the MD, but you can do just about everything, just not related to the surgeries, of course, but you're heavily involved with the daily activities of the MD.
Now you brought up schools, which is another a question the student asked. What are some kind of graduate schools that students should be looking into, whether that be from the east or the west or the Midwest or the Mid East, like that they should be looking to apply that will help get the education that they need. So like, what kind of graduate schools are out there that would best prepare people within allied health, pedagogy, or exercise?
Yeah, I can't speak to, I don't know, I can't speak to how great, some programs are. I did my PhD at a school called Rocky Mountain University of Health Professions. It's in Utah. That school now has grown to have occupational therapy. That's another major. Physical therapy, of course. Nursing. I mean, we haven't talked about nursing, but nursing is a great clinical major to get into. There's nurse practitioner, there's nursing assistants, there's doctorates in nursing now. Rocky Mountain has many of those programs. I would think now, because I'm not working for a university anymore, there are so many schools that provide so much education. It would be mainly just, searching out and doing the best you can, and making sure you talk to. What I always tell my students, when I used to run the masters in sports science at Rocky Mountain, and I would say to a new candidate, August, if you're interested in coming to the school, I'm going to give you two people to talk to. So I would be unbiased, because if I'm the program director, I'm biased. Sure, I want you to come to the program. You need to talk to an ambassador of the program currently. So can I talk to a student currently in your program? That was the first thing I would ask. And then, can I talk to a student who's been through the program? So two ambassadors, and that's probably the best thing to ask, because if you're being recruited, or you're interested in going to that school and that specific program, you don't want to talk just to the program director. He's going to be biased, or she's going to be biased. So you want to talk to somebody who's been through the program and who is currently in the program, and they should give you that information, or they can contact you. That'd be the best way to look at the program. So of course, do your due diligence and research online, do your due diligence and talk to people.
Yeah, well, everyone should know what they're getting themselves into before applying.
Oh yeah. Oh yeah, for sure. That's
another,
important.
go ahead.
Go ahead.
Another student question asks, what other majors or what other classes should you be taking outside of your major within the CSUSB kinesiology major?
I don't think anything outside. I mean, there are so many continuing education courses now. CEUs are big courses that people that hold a professional credential take to keep up these units that you have to basically turn in every year. It all depends on what you're interested in. If that person is interested in sports medicine, I mean, Rock Tape, the company I work for currently, we have courses on tape, courses on tools, but they're all pretty much medical. But we do have like movement science courses too. So it's really about what they're interested in. Taking extra courses, typically these programs will offer student discounts. So I would check out on student discounts. So there's so many things to look into. Trying to think about, obviously following a lot of people who you like to follow on social media will lead you to what you kind of like, whether it's, physical medicine, or whether that's physical therapy, or whether that's pedagogy. But looking into courses related to that, you also can look at a company called PESI, P-E-S-I, PESI. And if you go on PESI, their website, they have all kinds of courses you can take, from business to physical medicines. And these courses are fairly cheap, and they're 6 hours for the day, and you can learn something that you want to learn.
Another student asked, is research valuable in your undergraduate work?
That's a good question. I don't mean to laugh at it, but research is valuable all the time because it gives you informed information that's supposed to be unbiased. So doing research or reading research, you want to be the best consumer of research. You don't have to do the research. You don't have to do the research until you reach graduate school or you reach, terminal school like a PhD. But being a consumer of research, because information today, as you know, you are being molded by whatever information is coming through social media, television, radio, whatever. It molds a person. So it's up to you to have the clinical or have the critical thinking skills to decipher that information and make your own informed decision. And that's done through reading and done through reading unbiased manuscripts. So research is very important to understand the best unbiased decision. And then you can make that informed decision. Right now, people are making decisions on medical, on social, on psychological, all based on what's coming through their Facebook. Do you think Facebook is the best way to make your decision? Probably not, right? So we all know through Facebook algorithms that information is fed to you on what you want to learn, what they think you should have. So those Facebook algorithms are shaping your person's thoughts or your thoughts. So being able to read information, unbiased information, research from a good journal is very important. It is very important. You don't have to make the research, but you should be able to learn how to decipher the research.
That's very good advice. Another student asked, how has the kinesiology major at CSUSB improved over the years?
I don't know because I don't work for CSUSB, so I can't answer that.
What are another student asked, what are some jobs that undergraduate students can work to improve their candidate application for applying to like physical therapy school or any other graduate school?
Yeah, I mean, most programs now are going to request what we call internship hours or experience hours. So getting experience, clinical experience or hands-on experience with whatever field you want to go into, usually 50 to 100 hours prior to applying to those. They're going to ask for it. They want to see it. So getting ahead of that and being involved with a physical therapist at their clinic or being involved with an athletic trainer with their sports would be, it shows interest and it shows that you really do care. So getting the early hours is really important.
And this is more of my personal question. And then once left, Aaron or Maya, if they have any more questions about wrapping it up pretty soon. You mentioned PSI as a good place to learn other stuff. Is there any other websites or recommendations that you can recommend for me to learn stuff regarding anything really medically?
Yeah, so PESI is the one I mentioned, PESI, PESI. I don't want to push my own thing. I do work for Rock Tape, and if you're into sports medicine, sports science, Rock Tape has about 10 classes now. So rocktape.com. Sorry, that's not a plug, but you asked the question. I'm trying to think of other things, other avenues, other direction. I can't think of any offhand. I mean, PESI is the biggest continuing education business in the United States. So they have, I can't even tell you how many classes they have. So that's probably the best exhaustive list. But what you could do on any of those is you can look for something you're interested in, just type it in, and then type in continuing education. And somebody's probably teaching it somewhere because continuing education has almost become the new way to learn. Undergraduate is needed because it looks good on paper and it is needed to get jobs. Same with graduate school too. But there's plenty of people that have not gone through formal education, such as you guys are going through, and have just taken a plethora of continuing education courses to just learn more about what they want to learn. So again, going on rocktape.com, looking at a lot of those courses, even as a student, it's fine. And even PESI, looking at whatever their interests are.
Yes, definitely. Matt, Aaron, do you have any last minute questions about anything regarding anything about the presentation or about kinesiology as a whole? I suppose not then. Okay. Well, I'm going to end the recording. Thank you all for tuning in. And again, I'd like to thank Dr. Kinesworth for spending his time today and teaching us about pain and then providing all this information around the kinesiology meter. So thank you. And if you need more further questions, you can email me and then we can go from there.